This program is brought to you by Emory University.
Good morning, everyone. Welcome to our second Heart and Vascular Grand Rounds. It is my great pleasure today to introduce Dr. Olamide Alabi, who is a vascular surgeon and an associate professor in the Department of Surgery here at Emory. She also directs the endovascular services at the VA and is a chief quality officer for the vascular surgery group. Dr. Alabi went to undergraduate university at University of Nebraska, subsequently attended medical school there, and then did her general surgery residency at Loma Linda University in California, followed by fellowship in vascular surgery at Oregon Health and Science University in Portland. She's a member of numerous committees and 10 or more different societies that I counted on her CV. She's extremely active and really a triple threat. She is a part of, I'm just going to highlight a few of the committees. She's a part of the American Heart Association Council on Peripheral Vascular Disease and is the southeastern representative for the Venous Quality Council. Has also been involved in the ACC-AHA Clinical PAD Guidelines Peer Review Committee. She's on the editorial board of Annals of Vascular Surgery and is an active investigator in peripheral arterial disease and currently is also a PI on a VA Merit Award on defining causes to prevent major amputations in the veterans. I'm really excited to have you here today, Dr. Alabi, to give us this talk on peripheral arterial disease, quality, and health equity. I'll turn it over to you.
Thank you so much again for the invitation. Pooja, it's been a long time coming, I guess. I was trying to coordinate schedules and everything, but I'm very excited to be here this morning. So again, I'm Olamide Alabi, and I'll be speaking with you all this morning about peripheral artery disease quality and health equity, the intersection of those things. I don't have any financial disclosures that are relevant to this talk, but a lot of the work that will be presented here is funded by the listed agencies. And here's the objectives for the talk this morning. So this slide is a depiction of atherogenesis, or the process of atherosclerotic plaque formation. I use this to engage and disarm our basic and translational scientists because nothing about the rest of this talk will be about basic science. So sorry about that. But atherosclerosis, or the hardening and subsequent narrowing of the arterial wall, or some of us use the term injury to the vessel wall, develops slowly over time. And I know that this is nothing foreign to this group. Many people are familiar with the concepts of atherogenesis when it comes to coronary artery disease and cerebrovascular disease. However, from a population health standpoint, there's very little fuss that's made about peripheral artery disease, or the atherosclerotic cardiovascular disease equivalent that occurs in the lower extremities. There are about 12 million individuals in the United States with peripheral artery disease, or PAD, and that's an old estimate. The overall prevalence ranges in various published reports, between 3 to 10%. We also know that the prevalence of PAD increases with age. In the National Health and Nutrition Examination Survey, the authors found that the overall prevalence of PAD ranged from about 1.4% in individuals who are aged 40 to 49 to 16.6% in individuals who are over age 70. In fact, in a secondary analysis of this subgroup of the National Health and Nutrition Examination Survey, they stratified by the interaction between race and gender, with the presence of other cardiovascular comorbidities, and revealed population groups with a very high prevalence of PAD. So while in general, non-Hispanic Blacks had a higher prevalence of PAD than non-Hispanic whites, the highest prevalence of PAD was actually observed in non-Hispanic Black women over age 70, non-Hispanic Black women with chronic kidney disease, and Mexican-American men age 70 or older. And there are several known risk factors for PAD, as you can see and as you know, and there's a non-exhaustive list here. We typically concentrate on those that we know quite a bit about, so age, smoking status, diabetes, chronic kidney disease, etc. And I'll quickly go over PAD as a clinical syndrome, because I know that there are some learners on the call, just to make sure everyone's on the same page about how we diagnose and treat this spectrum of disease. So PAD is classified by the symptomatic manifestation that the individual displays at the time of diagnosis. So such that the mildest manifestation of disease is either no symptoms at all or claudication, which is reproducible pain that only occurs when one walks, and it abates with a short period of rest. The most severe manifestation of PAD is chronic limb-threatening ischemia, which often presents as ischemic rest pain in the foot or tissue loss in the form of non-healing wounds or gangrene. So we believe the majority of patients with PAD are in fact asymptomatic. And while we cannot clearly estimate how many asymptomatic PAD patients there are in our country or globally, what we know about this population is that their cardiovascular morbidity and mortality are real. This PAD diagnosis, even without symptoms, is associated with functional decline, and around 7% of them deteriorate to a relatively speaking mild manifestation of PAD called claudication over 5 years. And again, while asymptomatic PAD may not quite hold as high a risk of overall mortality as symptomatic PAD, the risk for mortality is still very much evident for those who are asymptomatic and have PAD. So these listed interventions, smoking cessation, lipid-lowering therapy, control of risk factors, behavioral and otherwise, and antiplatelet agents, have been demonstrated to improve survival in a heterogeneous PAD population. So for example, here's some data regarding statins. In a VA population-based study of over 150,000 veterans with incident PAD between 2003 and 2014, 28% of these patients were not on a statin at all. High-intensity statin therapy, however, was associated with decreased mortality and improved amputation-free survival in this PAD cohort. Again, intermittent claudication represents the mild manifestation of PAD symptoms, relatively speaking, where patients describe reproducible muscular pain, often in their calves, with ambulation that's relieved by a short period of rest. So to be clear, the management of all patients with PAD, regardless of their presenting or subsequent symptomatology, starts with guideline-directed medical therapy, which has been very clearly delineated by the American Heart Association and the American College of Cardiology, and others in terms of blood pressure, glycemic management, lipid-lowering therapy, behavioral modifications, etc. For claudicants in particular, there is a level 1A recommendation for walking or exercise programs. And several randomized controlled trials studying claudicants demonstrate improvements in quality of life with exercise programs and improved peak walking time and distance without pain with supervised exercise over pharmacotherapy alone. For those with disabling or lifestyle-limiting claudication, we typically offer revascularization. Chronic limb-threatening ischemia, or CLTI, I'll refer to it later in this talk, is the most severe manifestation of PAD. Some people describe it as end-stage PAD. This is a limb-threatening diagnosis marked by wounds that will not heal because of insufficient blood flow or gangrene, or frankly dead tissue on the toes or forefoot. It's no longer possible to describe the natural history of patients with CLTI because the majority of these patients now receive some form of active treatment. However, regardless of what that treatment is, up to 30% will progress to major lower extremity amputation within 1 year. 25% will die of cardiovascular complications within 1 year, regardless of treatment. So again, every patient with chronic limb-threatening ischemia or CLTI should be started on guideline-directed medical therapy, and then there are typically several decisions that have to be made. These decisions range from revascularization, which a large proportion of those individuals get, to primary lower extremity amputation, to palliative wound care. And if the patient's a good candidate for revascularization, there are several ways and techniques that can be used to achieve this, both through open surgical bypass and endovascular intervention options, as well as hybrid options. So why does all of this matter? Putting it in perspective, over 185,000 major lower extremity amputations occur each year, and almost 2,000 of these happen within VAs. Nearly 2/3 of those individuals who undergo major amputation have diabetes, and just under half identify as a race other than white. Specific groups are at higher risk for major amputation compared to others. Claudication as a disease state is, relatively speaking, benign. Based on all the available evidence and updated guidelines, as well as the Society for Vascular Surgery appropriate use criteria, claudication should be treated with upfront exercise therapy, with primary revascularization being reserved for a small portion of those who present with claudication. A lot of people kind of hem and haw about this. They want to provide interventions for these individuals. But think about it this way. When you have claudication, your risk for amputation is quite low, about 1 to 2% per year, no higher than that. But if you start out with claudication, undergo a revascularization, and then progress to CLTI, that end stage PAD, your risk for amputation is now 1 in 4 to 1 in 5 per year. And that's a very real problem, that progression of disease, a problem that we should take note of. So a quick introduction to Quality 101. A quality measure is a broader, often more structured framework that defines the specific metrics, criteria, and processes for evaluating quality against a standard, frequently incorporating structural, process, and outcome components to assess overall care or system performance. So these can include structural measures, assessing the characteristics of the care setting, including facilities, personnel, or policies related to care delivery, such as do you have ICU specialists on staff 24/7, daytime hours, etc. Process measures determine if the services provided to patients are consistent with routine care delivery. So, for example, preventive screening. Does an individual physician or their group, a physician group, ensure that patients are prescribed and or receive recommended cancer screening or flu shots, etc.? Outcome measures are the measures people are most familiar with, so survival. Often when we talk about surgery or surgical fields, within 30 days, this perioperative time period. Specific complications related to procedures, readmissions, etc. Patient experience measures are becoming more better identified and recognized. So this is, do patients report that their provider explains their treatment options in ways that are easy to understand? Or patient satisfaction scores, which we're all familiar with. The field of vascular surgery is ripe with innovation, and not just with devices that we use to improve blood flow. Unlike in the management of coronary artery disease, which is fairly straightforward and regimented algorithms of care that are present based on acuity and based on endovascular versus open surgical management, that is very well established in your all's field. But for peripheral artery disease, the space kind of behaves a bit like the Wild Wild West. And given this, we have a lot to learn and define as it relates to better understanding PAD and what exactly quality care for a patient with PAD means. So I felt that there was a large focus on PAD outcomes that were important to providers, like bypass graft or stent patency, amputation rate after revascularization, which is also important to patients too, or target lesion revascularization, which some interventionalists don't even know what that means. So, however, there's very little or nothing really known about what's important to patients or how to measure it. So sure, patients care if they lose their leg, of course. They care if their stent or their bypass fails, and particularly if it fails early and they develop symptoms again. But what they care more about is how much pain were they in, and did the surgery that they had make that pain better? Or that wound that I've had for a year and I have to let people into my house 3 times a week to dress it, did that surgery help that wound heal? And how long did it take? Because it never takes just a month or 2. So as concluded in the systematic review that we published way back when I was in fellowship, although no strong conclusions can be made to guide clinical practice, it does appear that despite optimal limb salvage and revascularization patency rates, what a provider might deem as reasonable functional status after intervention and the ability to live and function independently after the procedure, patients do not always experience significant nor sustained gains in their health-related quality of life. It does, however, appear that repeat procedures or reinterventions, whether open surgical or endovascular, likely adversely affect quality of life. So we wanted to dig into that more. So for some background, the number of lower extremity revascularizations continues to increase, and the proportion of these revascularizations that are performed via endovascular means is also increasing. 30-day readmission after a PAD revascularization has been estimated to range anywhere in the literature from 18 to 30%, with over a quarter of these being due to procedural complications specifically. But emerging data has demonstrated that readmission for patients with PAD does not stop or slow down at the standard 30-day postoperative window. In one study, while the 30-day readmission rate was 14%, they determined that the readmission rate between 31 and 180 days after a PAD revascularization was 48%. So why is this important? In the setting of increasing volume for lower extremity revascularization and subsequent post-procedure complications, the CMS Payments Advisory Commission identified vascular surgery procedures as one of 7 groups responsible for over 30% of potentially preventable readmissions. So as the United States healthcare systems continue to evolve, there's greater focus on the development of payment models that focus on value and not volume. And towards that end, CMS launched the Bundled Payment for Care Improvement Initiative in 2013 and its successor, BPCI, advanced in 2018. These pilot programs move away from a fee-for-service model of linking payments for individual services to providing a single bundled payment for an episode of care that's triggered by a hospital admission and extends through 90 days after discharge, and in turn holds the healthcare organization accountable for costs incurred during this episode of care. So while the goal of this 90-day based model is for healthcare organizations to provide quality healthcare that is better coordinated, more efficient, and potentially cost effective, it's unclear what the rates of readmission look like beyond 30 days, which has historically been the standard post-procedure reporting window. And so we looked specifically into that. Our work leveraging a vascular procedural registry linked to Medicare claims data over a 9-year period showed that in a group of about 40,000 patients who had a PAD procedure performed, 18% of them were readmitted within 30 days, and 31% were readmitted within 90 days. Factors associated with 90-day readmission were all the comorbidities of interest that we analyzed, as well as procedural site, with inpatient procedures being more likely to have a readmission event than those PAD procedures that were performed in the outpatient or office-based setting. Similarly, we looked at 30-day reintervention and 90-day reintervention, of which after a lower extremity revascularization, within 30 days, 5.5% were getting reinterventions, and within 90 days, 14.5% underwent a reintervention. And so factors that were associated with 90-day reintervention again included procedural site, specifically those who have procedures performed in the outpatient or office-based setting. And it's important to note that over 64% of those who had those procedures performed in the outpatient setting were claudicants, and nearly 2/3 of them had single segment interventions in the femoral popliteal segment only, as opposed to those with CLTI who often have multi-level disease and have to have multi-level revascularizations. So taking this a step further, we have evidence in other surgical specialties that readmission care fragmentation is bad for a number of reasons. However, we don't know much about what happens if you're in fact readmitted after a lower extremity revascularization, but you get readmitted to a facility other than the place where you had your initial or index revascularization performed, meaning are your outcomes comparable? Utilizing this same procedural registry linked to Medicare data, we also linked this to the American Hospital Association annual survey. We examined that among only those who underwent lower extremity revascularization and were subsequently readmitted after their indexed lower extremity revascularization, 27% of these patients who were readmitted to a non-index facility, so about 1/4. Readmission to a non-index facility was not associated with 90-day mortality or amputation at 30 or 90 days. However, if you have a procedure-related readmission, this in fact was associated with amputation at 30 days as well as at 90 days. And so we wanted to explore this further and include reinterventions. So thus we explored reintervention care fragmentation after a lower extremity revascularization. We only looked at those patients in our combined data set that had a reintervention after an index lower extremity revascularization. And this time we employed a mixed effects model clustered at the facility level to evaluate the primary exposure of site of first reintervention, whether they had an index facility or whether they were at an index facility or non-index facility for their reintervention, and what their outcomes were at 90 and 180 days. So 18% of those patients who had reintervention after a lower extremity revascularization had their reintervention at a non-index facility, about 1 in 5. We found that these were more often than not in individuals who were Black, individuals who had congestive heart failure, diabetes, were on dialysis, or had a prior amputation. And importantly, reintervention at a non-index facility is associated with amputation at 90 days as well as at 180 days. And given these findings, we seek to better define who is at greater risk and what optimal care coordination after a PAD revascularization actually looks like in certain centers as well as certain communities. So because of this, we've dedicated a lot of time to defining and describing practice patterns when it comes to process measures. Many studies report that Black and Brown patients present with more advanced disease, and this is the reason why they suffer from higher rates of amputation. And while this may be often the case when it comes to presentation to a vascular surgeon, there is data from the VA that suggests that in the year prior to a major amputation, only 8% of all veterans with an amputation did not see their primary care provider, a vascular surgeon, a cardiologist, a endocrinologist, or other specialty providers that these patients typically see with some frequency, meaning that the vast majority of patients were plugged into care in the year before their major amputation. Among this cohort, Black veterans were just as likely to seek care as white veterans, suggesting that in this population, Black veterans are trying to get the care that they need and starting with the usual teams, such as primary care providers, podiatrists, wound care specialists, etc., as often as white patients. So notice how we're reframing this to take the blame off of the patient, because they are actually plugged into care. They're trying to do the right things for themselves. They just need to get to the right people or the right specialists. So Phil Goodney and team, he reviewed Medicare beneficiaries almost a decade ago to determine who was and who was not getting revascularization in the year prior to a major amputation. His group found that 54% of patients did not receive revascularization within the 1 year prior to their amputation, and Black race was significantly associated with not receiving revascularization. I think it's important to find good models of care by which we can emulate. So I asked a similar question among veterans who underwent amputation and found that number one, overall, 70% of veterans get an imaging study and or a revascularization in the year prior to an amputation. Again, this is compared to the 46% in the private sector that are getting this. And number two, Black veterans were as likely as white veterans to get an ankle brachial index prior to amputation, and were just as likely as white veterans to get revascularization prior to their amputation. So some of the things that we're seeing within the private sector don't necessarily happen within the VA. We've also found since that there's no association between social vulnerability to any degree and receipt of vascular assessment, or that study that will look at your blood flow plus or minus a revascularization procedure to improve your blood flow within the VA for a patient who undergoes an amputation within that 1 year beforehand. My lab seeks to delve into this further in order to better understand facility and regional level factors that paint a picture of how care is provided within the VA, and how we can help make strides to eliminate the specific process measure disparity that we see in the private sector, but don't see within the Veterans Health Administration. So equitable care for PAD patients has largely focused on the end stage group of patients, but what about our patients with this milder form of PAD that I mentioned before, claudication? So remember this rate of progression or rate of disease progression over time throughout the PAD spectrum of disease. This is an aggregated rate, but does the rate of disease progression differ between communities? We had this specific interest, specifically with intersectionality in mind. Intersectionality is the framework that sees a person as multidimensional or a product of all of their social identities, not just one social identity. So we looked at intersectional identity, a combined variable of one's race, ethnicity, and sex, and found that intersectional identity is associated with varying rates of progression of CLTI for patients with claudication after a revascularization. We also found that disease progression for a claudicant to move to CLTI after their revascularization for claudication was worse among Black women in particular. In fact, the 1 year rate of disease progression in CLTI among Black women with claudication after they undergo a revascularization is almost 1 in 5. Comparatively, about 13% of Black men and Hispanic men progress to CLTI, and only 9% of white men progress to CLTI after a revascularization for claudication. So you kind of think, you look at those numbers and you think, well, where do you even start? Like, how do you, it sounds like a really big problem. Like, where do you start to try to fix it? I think first we need to better understand it. I'm sure that by now everyone's familiar with the concept of social determinants of health, examples of which include access to care, safe housing, pollution, discrimination and stress, education, income, health literacy, disease-specific knowledge, etc. We need to leverage what we know about social determinants of health and create change. I'm going to spend a little bit more time, I'm going to spend a little bit more time on the concept of the political determinants of health. because I believe that this is a term that people are less familiar with. So the political determinants of health are the creators, exacerbators, and perpetrators of very specific structural conditions, and they're arguably the factors that continue to drive health disparities to this day. So for example, in the 1600s, policymakers, along with business leaders, created facially discriminatory policies that explicitly prohibited Black and Indigenous people from raising their own food, earning their own money, learning to read or write, moving more than a mile away without a permission slip, socializing or worshiping in unsanctioned areas, etc. These policies distributed resources, they allocated power, and they sanctioned neighborhood disinvestment and structured relationships that have created and fueled health inequities to this day. Policies such as these determine where factories with hazardous waste or air pollutants go, where highways were built, where fast food restaurants are more likely to be placed, where a Whole Foods was not likely to be placed, and where people who are phenotypically very similar to me live in relationship to those things. We also never really like to talk very much about bias when we mention racial disparities in healthcare, but because we'd like to believe that we provide the same level of care and the same resources to all comers, but we have to believe, given all the available literature, that that's not exactly the case. So let's talk specifically as it relates to PAD. We know that statin use can reduce the need for amputation with relative risk reductions between 18 to 35% that were not seen with non-statin lipid-lowering therapy. We also know that patients from Black and Brown communities who are candidates for statin therapy largely do not get it, nor do most patients who undergo a major amputation get statin therapy. We know that once diagnosed with a mild manifestation of PAD or claudication, the evidence-based treatment is guideline-directed medical therapy and the prescription of exercise therapy, as mentioned. We also know that Black Americans with PAD suffer a greater degree of functional decline over time when they have claudication, and this may be related to less access to exercise in their communities, as well as socioeconomic status. We're learning that supervised exercise therapy has a greater impact on quality of life among Black Americans compared to non-Hispanic white Americans, with Dr. McDermott's work out of Northwestern. But again, Black and Brown communities are not prescribed supervised or home-based exercise therapy at the rate that non-Hispanic white patients with PAD are. And to be completely honest, no one is prescribed the exercise therapy at the rate that it should be. Black patients suffer overutilization of revascularization when they present with early manifestations of PAD. Perhaps sometimes when this revascularization may not be indicated, but they suffer from a lack of utilization of these same procedures when they matter most, or when they present with end-stage PAD or CLTI. And when given a major amputation, Black patients are more likely to undergo above-knee amputation compared to below-knee amputation, which has significant implications on future prosthetic fitting and subsequent ambulation, and very well may contribute to early mortality. And this can be unpacked even further with further data. Overutilization of procedures in claudication, but not in CLTI, as previously mentioned. When individuals come in with CLTI and they're found to need to have a bypass surgery, Black patients are more likely to get vein mapping, but they're less likely to have that vein used for a leg bypass. The New York Times put our entire field of vascular surgery and vascular interventionalists on blast, and for better or worse, reignited a national conversation that quite frankly needs to be had among interventionalists with their patients as well as with their caregivers. But it's yet a further reminder that the public, which includes our patients, demands more from us. And so what does more look like? The more looks like standardized care, clearly defined quality PAD measures, benchmarked PAD quality metrics, and the development of value-based care programs that focus on these. So there are several approaches to achieve or optimize equity in our practices. It starts with acknowledgement, though, understanding your patients and subsequent outcomes, recognizing all stakeholders, but then it moves to understanding that equity is not a problem that can be solved one patient at a time. It requires creation of an environment where evidence-based care is offered in a standardized fashion at the system level and on down. This means ensuring you have team members with the requisite skill set and expertise to provide the care that our patients need. And this is an old picture of our division. Hopefully we'll get new pictures of our division. We just took them a couple weeks ago. This also means working in collaborative groups with people or high impact societies that specialists in your field are not traditionally engaged in, to ensure that your voice or perspective is included and make sure that real change is happening and not just the talk of change. So my role within the American Heart Association's PAD Collaborative, we created a national amputation heat map that tracks amputation rates by census tract throughout the United States. And we found that one of the highest amputation rates in the country was in our backyard. So Congressional District 2 in Georgia ranks number 11 highest amputation rates in the country. So with support from Dr. Abi Goyle as the Chief Quality Officer for Heart and Vascular Service Line, we've created a vascular surgery dashboard to examine specific vascular surgery procedural types performed within Emory Healthcare and to better understand the volume, demographics, and outcomes for our patients who undergo specific vascular procedures at each of our sites within our system. So we looked at where our patients with peripheral artery disease who undergo revascularization are coming from. We also reviewed where the patients who have a major amputation performed within our health care system reside. And while this showed that we do care for some of the patients in this part of the state, that Congressional District 2 that I mentioned, our presence in that area and for those patients is limited compared to those within our primary service areas and tertiary service areas. So, however, as you can see, Emory Healthcare's footprint is expanding. I didn't put all the ones in the metro Atlanta area, but you can see, as you guys know, in St. Francis and Columbus, and then our new acquisition down in the Warner Robins area. As such, our team applied for funding and were awarded a vascular care for the underserved grant. As part of this multi-pronged effort, we're traveling to South Georgia cities such as Valdosta and Bainbridge in order to provide circulation health screenings to migrant farm workers and their families, as well as other underserved populations in those areas. We previously already went to Valdosta earlier this year with a very large group of individuals. This is largely PA students, nursing students, and then their preceptors. This is the first time that they brought vascular surgery down with them, vascular surgery and podiatry. We saw some of our heart and vascular friends. Some of you in the congenital group may recognize this face here. And we also met with several other individuals who came up even as far as the Dominican Republic to help in this effort. So a very large effort, multi-pronged approach, and we're trying to use data to lead us to these areas so that we can provide care to the state and improve access to such care. So we're making the case for families. We all have a family member, or have heard of a family member, or a friend, or perhaps even a personal story where someone received less than the standard of care and fell victim to poor quality care. But many of our patients, not just our patients, our neighbors, our kids' teachers, our family members, and our friends, they fall victim to poor quality care. I'll just tell a very quick story so that you guys can kind of understand this more from a personal element. So over here, this is my father. He immigrated to the United States in the 1970s. He went to Nebraska, of all places, and he studied there at the University of Nebraska to obtain a degree in agronomy. So while he was studying for his PhD in agronomy, he met a Haitian immigrant who came to get his PhD in civil engineering. They became close friends. And then myself and his daughter became best friends. And I remember us taking a trip to the Caribbean. It's a very long time ago. That's a flip phone in my hand. So very long time ago, but we're taking a trip to the Bahamas. And her father gives us a call and says, you know, I checked my blood sugar. It was running really high. I wasn't feeling very well. So I went to the hospital in Lincoln, Nebraska, where we lived. And when I got to that hospital, you know, they put me in a gown, they look me over, they are treating my blood sugars with insulin. And they find, because he likes to wear these boots, they find that there's this area on the side of his fifth toe that, for better part, you know, all intents and purposes, is really just a superficial abrasion of his skin. But they felt like it looked like a wound or some sort of wound that may be associated with his diabetes. And because of that, they told him that the only definitive way to treat his diabetes and his high sugars that he came with and make him feel better is to amputate his leg. And there was no x-ray that was done. There were no non-invasive vascular labs. There's no ankle brachial index, no CT angiogram of the lower extremities, no revascularization, nothing. No even checking for pulses. There's just your sugars are high, you have a wound on your foot, you need an amputation. And he refused, and he called us, and we refused. And I can tell you that the only unique part of this story is the fact that he refused. And there are, again, a lot of individuals in our communities, some of these people we know, some of these people we do not know, who fall victim to poor quality care. And these patients are real. They have families, they have friends, they have desires to have futures as well. So, in summary, patients are people first. They deserve good care. We have to figure out how to deliver precision PAD care to the right patient at the right time, the right place, the right treatment, and the right surveillance. And again, if PAD is a disease that is largely driven by how you present and where you start, then standardized care algorithms that include pharmacoequity in the form of guideline-directed medical therapy, interventions when warranted, and the right intervention, so a multi-level intervention for multi-level disease, and changing the focus to value over volume, or while we can accommodate greater volume, is how we can change the way that our patients finish. So I'd like to give some acknowledgements to my family who have driven me in all ways, in all aspects, my lab and mentees, vascular surgery as well as general surgery trainees that we work with, who we learn from every day as well, and then also my boss over here, Dr. Jawari. And let's make the case for our patients and our families and for our children and for our future. And I'm happy to take any questions for those who have them.
Great. Thank you so much for that wonderful presentation. Congratulations on all the work that you've done. It was just really nice to see, and especially with the things that are happening in Georgia and the things that you're doing with the group there in South Georgia. So thank you so much. I'm going to open it up for questions. This was really a very unique PAD talk because not only it's about the actual disease, but also how to improve quality. And you've gotten us all very excited about this now. So while we're waiting for questions, I'll start off with one. Claudication, I think of that as angina, right? And you can have claudication, but not necessarily have a need for revascularization. So can you tell us, claudication by itself, is that a covered diagnosis for exercise rehab prescription? That's the first question. And then exactly how do we, because is it part of cardiac rehab or exercise? So, how long is the duration before somebody kind of graduates from an exercise rehab?
Yeah, great questions. So yes, claudication is a covered entity for structured exercise therapy and or home-based exercise therapy. The problem is the availability or lack of availability of those programs. I would say that locations that have successfully built it into their institutions are usually institution-based and usually coupled with cardiac rehab. I don't want to speak for individuals. I can see some of them on the on the call right now who have been working on this for a very long time here at Emory to be able to develop a structured exercise therapy either through cardiac rehab or very similarly modeled to cardiac rehab that already exists here. But those efforts are still underway, and hopefully within the next year or two, perhaps will be established here at Emory as well.
Great. I see a question in the chat by Karen Bauer. Good morning. Will you please touch on the PAVE program via VA and your perspective on it?
Yeah, so the PAVE program, Preventing Amputations in Veterans Everywhere, it's a well-established program within the VA. It's multidisciplinary. Often you will have a lead podiatry individual who's working on the team, as well as a lead vascular surgeon that works on the team. So kind of a toe and flow model, if you will. In successful PAVE programs that I've seen throughout the country, many of them, I did my surgical training on the West Coast, so many of them that I saw in Southern California as well as in Oregon, these individuals are having weekly conferences together about joint patients or joint types of problems. For example, what should be the threshold of some sort of non-invasive vascular lab, like a toe pressure or a transcutaneous pressure of oxygen? What should be that threshold that we use within our institution to say that a wound can or should be given a chance to heal on its own or requires revascularization in order to heal? So they develop those kind of algorithms within their own group. and then they follow them. Many times they're also rounding on inpatients together. So as a large team, podiatry specialists and their residents and learners, as well as vascular surgery specialists and their residents and learners. I think in some of the more mature teams, PAVE teams throughout the country, there are also infectious disease team members that are present, and sometimes vascular medicine specialists if they exist within that VA as well. So a very multidisciplinary approach. The work is truly done together. And it's no one is separated or siloed in those types of teams. Hopefully that answers your question about the PAVE program.
Great, thank you. Any other questions or comments? I'll ask another one while our audience is thinking, because I know everybody has questions. Oh, Dr. Smith has a question. Go ahead.
Yes, I'm working at Grady, specifically related to patients who have heart failure. And with heart failure, one of the CMS things is related to readmission rates. And at Grady, we actually have a gold star rating with the American Heart Association related to care that's provided in the hospital and in our clinics. But we're really struggling with our CMS data on readmissions. And as we look into this, part of the issue is it's just related to Medicare patients. And it turns out that a lot of our patients have Medicare Advantage plans and don't go into that system. So, but also, I mean, we have systems in place for patients who don't have housing. We're trying to work with Mercy Care to go out and help these patients. We have a mobile health service where they can actually go into the homes, and yet we have patients who have mental illness, have addiction disorders, do not have housing, that are getting readmitted. And so your talk, you focused on in part that this issue of readmission is related to us not doing enough as healthcare providers. And I want to challenge you on that because what I'm seeing within our care at Grady is that we are trying to do a lot, and we have a lot of things in place, but we're struggling. And yet these metrics and these outcomes may actually penalize us and penalize our patients ultimately. So I'm just interested in your response to that.
Yeah, no, I'm aware of some of the programs that you all have established, which are very novel programs. I can't say that a lot of people, even in the city or throughout the state or the nation, employ as many programs as you all do there. So, kudos to you for all the work that you and your group have done. I think that when it comes to, I'm not trying to lay the blame on a patient or a provider for any specific outcome that a patient has, specifically when it relates to readmission, et cetera. I think what we do need to think about is think more holistically, as you mentioned, about the patient. We may be treating their heart failure. We may be treating their chronic limb-threatening ischemia. We may be treating whatever pathology that they came into the hospital with, PE, whatever it is. But the patient is more than just the diagnosis that came in the door. So I think it's really important to employ some of those novel techniques, like you mentioned, whether that be telehealth to kind of check in on a patient in an interval that you maybe wouldn't have checked in on the patient. Like maybe if your standard follow-up schedule is usually about a month after their discharge, maybe a 2-week follow-up with a telehealth or with a community health worker. A lot of practices are employing community health workers. So these are individuals within the community with good standing within their communities. So people that some of our patients can trust a little bit easier than us, and also people that can speak to the community on their level. And not at the level sometimes that we speak with, like medical speak, etc. I think those things can be helpful. I think also, like you mentioned, some of these mobile companies such as Dispatch Health or other companies such as that, where we can employ or deploy some of these resources into a patient's home. Not quite like home health, it's not for like specialized dressings or anything like that, but mostly to check in, make sure that they're keeping their blood pressure logs, or make sure that the home health companies are actually showing up and doing the work that they were contracted to do, etc. So I think really what a lot of our groups, when possible, should move to is what Dr. Smith, you're just mentioning, utilizing a lot of those novel techniques that really take into account the whole patient, a holistic care, as opposed to just the diagnosis that they came into the hospital for.
Thank you. I'll ask a question. So Dr. Magoris has a question. Do you use exercise ABI?
I do use exercise ABI, and our vascular labs throughout Emory Healthcare are also equipped to be able to provide that for any patients that you feel it may be necessary. I would say largely in my practice that typically is for patients who maybe have, quote unquote, normal resting ABIs or maybe barely diminished resting ABIs, but are describing either classic or maybe non-traditional claudication type symptoms. And it's almost like their walking stress test, if you will, to be able to determine if their symptoms are really truly related to arterial vasculogenic claudication or another pathology.
So on a related question then, we think of ABI as screening test, and of course for sort of risk stratification, we use that in primary prevention. But if somebody, a lot of our patients as cardiologists, they have CAD. And, we see on the problem list, there's diabetes, CAD, hyperlipidemia, hypertension, your most four common. And we just kind of rely that, okay, primary care will, because they have diabetes, they're going to do the retinopathy screening, PAD screening. But obviously, I'm sure, that doesn't happen. So would you recommend that we just go ahead and order ABIs in these patients or exercise, obviously claudication, if they have symptoms, then we'll do the exercise ABI, but should we be doing ABIs in these patients?
I don't think it's unreasonable to obtain an ABI in a patient that either you check their feet, you have a concern, you try to feel pulses, you don't feel pulses, you have a concern, particularly in these individuals who have several risk factors, which are all the patients that you all see.
Yeah.
So, so I don't think that's unreasonable, whether they're symptomatic or asymptomatic. Now, when it comes to reimbursement, that's the tricky part. The USPSTF has maintained, or at least thus far maintained, insufficient evidence to recommend screening for PAD for a number of reasons. I think largely because they don't feel like there's enough evidence to suggest that it would be cost effective or helpful for individuals. But then you see those statistics like 185,000 lower extremity amputations every year, and you kind of wonder, do they see those statistics? And so I think hopefully the pendulum is swinging with a lot of the work that the American Heart Association is doing, particularly the Peripheral Vascular Disease Council, a lot of the work that they've been doing over the years with several different leaders in vascular medicine, a few of them included on this call in our institution. I think that the pendulum hopefully will swing so that reimbursement can be better for ABIs in patients, and there be more reasonable screening guidelines in that regard.
All right. Well, thank you again for a wonderful talk.
No, absolutely.
Right.
Thank you so much for having me this morning. It's always a pleasure to talk with colleagues.
Okay, great. Thank you, everyone. Have a great day, and don't forget to get your CME.
The preceding program is copyrighted by Emory University.